Hello and welcome to Next Phase, where we examine the intersection of health and technology and talk about the future of our health system. So today I'm delighted to welcome Dr. Jagdeesh Dhaliwal. How are you, Jag?
Good, thanks, Simon. Thanks very much for inviting me.
You're welcome. You're welcome. You've got a particularly interesting bio that I think I'll need your help to make sense of. But from what I can see, you've spent over 2 decades in England working with the NHS as a primary care doc, and you've been out here for, is it 4 years now? So you're practicing GP in the aged care space, but all the way through your career, you've had roles that have been active in policy, in government, in leadership, and more recently with technology. So can you help make sense of that for me?
Sense of that. Well, I think, Simon, like a lot of doctors, and this isn't just something you said in the interview, but I genuinely went into medicine because I wanted to make a difference and help, and help people. And I really enjoyed doing my medical degree, and then you come out after doing your hospital attachments, and I'd always knew I wanted to do general practice because I really like that ongoing longitudinal relationship with patients. And I thought, great, I'm a doctor now, and I'll go off and make a difference. And probably like a lot of doctors, you get to your first few months, you realize this isn't going quite the way that I thought it would go, because yes, everything that I've been taught around medicine I could put into practice, but there are some blockages here that are stopping me, really being able to help. And then I think it was an analysis of, well, what are those blockages? And those blockages were actually nothing related to medicine or clinical practice. It was to do with things around processes, leadership, management, organizational culture. And I think, understanding that these were the reasons why either things succeed or didn't succeed made me curious and made me feel, right, I want to go off and learn about this. So I was just very fortunate that quite early on in my career, I had the opportunity to pitch for a medical director role, and was fortunate enough to be selected. And that was just really a seminal moment, I think, for me in terms of my career, because I was a jobbing, coal-faced clinical doctor for part of the week, and the rest of the week, I was brought into an NHS trust to look at organisational challenges, and you just start to see the world in slightly different ways. And then, having realised that I had this new set of challenges, I realised that my clinical skills, expertise, my training wasn't actually what I needed to be able to help me to move forward. So I then went off and did my own master's in health services management, and that was like the lights being switched on. You suddenly have this theory and and constructs that you can use to the everyday practice that you've got. So essentially, my career has consisted always of 3 things. I very much love being a coal-faced jobbing GP, a jobbing doctor. And then I'd like having management roles, because I think being able to have some sort of input at a strategic level and a contribution, being able to talk about what's happening at the coalface can be useful. And then the third bit is, maybe a bit more an academic leadership type of sort of facet to it, where you think about concepts from the broader management literature, and sort of using that as intellectual fodder, really, to be able to feed what it is you want to do in the career. So that's been my aim for my career, to have those 3 elements covered.
Yeah, great. That's pretty extraordinary, because what it gives you is a bit of a unique view. You see both sides of it as a practitioner and as an organiser of how services get delivered. In this COVID situation, that's got to be particularly interesting, because we're seeing disruption across the primary care and outpatient specialist arenas. What do you see that's changing now, and what do you think might be different about the new normal out when we come out of this?
Yeah, I mean, lots of interesting things, I think, Simon. So, I think what you touched on there, this idea of being able to see both sides of an experience is probably something that really interests me. So, for example, I love languages, because it's really nice to be able to see the world through a different lens when you speak another language. And it's nice being an expat, an immigrant to Australia, because I can see things from my from a British angle, but also an Australian angle as well. So one of the things that I really love about Australia is, an Australian culture in health services, is that when something innovative happens, we seem to just grab it and just run with it. Whereas one of the things that I love about the UK and also really frustrates me about the UK is things can be ever so slow. So change there can happen quite slowly. So what's been absolutely amazing is the way that the item numbers came out for telehealth at the outset of COVID, and by and large, the vast majority of our colleagues in whichever medical specialty have grabbed hold of the opportunity to be able to serve patients in different ways, and really wonderfully innovative things are happening. So I remember a consultation a couple of weeks ago. It was myself, a vascular surgeon, and an elderly patient who would really have struggled to get to an appointment. And then we had nursing input as well, and we also had a physio involved on a teleconference. Now, that technically could have happened, but because we didn't have the mechanics set up in terms of Medicare, it wouldn't have happened. And so elements such as that I find incredibly exciting, because that you just know. I mean, all of us do, don't we, Simon? When you go home and you reflect on a day, that was a good day, because you've really, really done something worthwhile there, a really rich conversation, and all of us individually said how working in our silos, we do a good job, but bringing the collective together in that way was just tremendous. And you've probably got a much more thorough, comprehensive, holistic answer for that patient and his family. And also it was done in a much more time efficient way, rather than sequential sets of consultations to that patient. It was just done all together over 45 minutes or so. So elements such as that, I think, make me ever so excited, and I would hope and I think that those elements will stay.
I think that's really interesting, because what you've done is you touched on some of the challenges that are inherent in any health system. One is access, and in this instance, especially where you work in aged care, they're mobility impaired and sometimes need assistance getting from appointment to appointment, which is the next problem, because the patient becomes the integrator in a fragmented health system. And here we've got technology that's kind of been used expediently, because it's the one way that we can connect with people during this period of social isolation. But what it's doing, I think, is opening up access. It's creating a level of equity that we haven't seen before across our health system, and we're probably bringing health forward into the modern arena, maybe faster than we've ever experienced changed in certainly the last 20 years.
Yeah, absolutely right, Simon. It's interesting because you, in reflecting on our conversation beforehand, one thing that I'm still trying to process is, so if you'd asked me at the beginning of the year, before all of this was on the horizon, okay, supposing Jag, you can, we can set up telehealth. What do you think the gains will be? I would have said, okay, so we will save on travel time, maybe to our places of work, and we'll find that if we're doing 100%, telephone consultations, it'll just be much more efficient in terms of time. And interestingly enough, Simon, that hasn't been proven to be the case. Because one of the things I think I've found is, so I remember consulting for, it was just shy of 3 weeks, purely by video. And interestingly, that wasn't as effective and efficient as the situation I've moved to now, which is actually a hybrid. So whereas I might have, for example, attended an aged care facility 3 times a week in person, I now will attend once in person and then twice by video. And that seems to be a happy hybrid. And I think the reason why the pure telehealth wasn't quite as effective was, it's something just to do with, I think, human beings and being in the same room as somebody, and that sense that, you can sort of sit down and then people will start to talk about things that they might not talk about on a video. So I tend to kind of pick up things that just don't seem to come to the fore, when we're having a video consultation. And I think maybe in process terms, there's maybe something about, if you've got quite a linear process that, a patient wants X and X is defined, then a video makes sense. You have a video call, you talk to the patient and then the service is provided easy. But actually, when there's more complexity involved, where maybe it's in, Keith Grint, an ex-colleague of mine from Warwick, talked about wicked problems. So wicked problems where the patient really isn't aware of what the issue is, doctors, there's diagnostic uncertainty. Something about the face-to-face consultation, or maybe face-to-face consultations mixed with video, I have a hunch probably leads to a more effective outcome. And I think probably the sociologists have a field, or psychologists have a field day with this, trying to understand what it is. Video maybe isn't quite at that level. I don't know if that's something you've experienced, Simon.
Can I paraphrase that? Because I think you've hit on some really important things. So telehealth won't replace face-to-face medicine, but it's an important parallel adjuvant model that does increase at least convenience and access to care. So I guess that's the first thing. Second thing is telehealth isn't for everyone. There's a time and a place where it's useful, and others where a face-to-face model will be preferred. And the big question at the end of it, that I'm polling everyone, do you see telehealth persisting after the COVID crisis has passed? Do you think the item numbers will be wound back and we'll go back to the old way of doing things?
I think it would be such a retrograde step if we did that, for all the reasons we've talked about, in terms of effectiveness. I know in aged care, for example, whereas before, a patient who'd maybe had a fall, a locum would be called, whereas now, by telehealth, a doctor that knows the patient can actually have a conversation, and then have a shared decision-making conversation with the family as well. And we can all do that virtually, which is just tremendous. Which is, streets ahead of what was happening before, because I have no doubt that that's resulting in fewer hospital admissions and just better quality care. And also, let's not forget the environmental impact of doctors, nurses, other healthcare professionals jumping in cars and driving around kind of remote areas. So I think, for environmental reasons as well, it would be such a retrograde step if we went back, and very short-sighted, I think.
Something we used to do in primary care a lot 30 years ago was the house call. And we don't do that so much as part of routine practice, but especially for vulnerable populations, including the elderly, that concept of being able to access medical care where you need it rather than where it's convenient for the provider is very important. How have you found that the elderly take to the technology of telehealth? What's their experience?
I probably have more experience in this regard in England, Simon. So certainly in my practice in the UK, we were quite avid adopters of this. So we found that firstly, I felt really quite embarrassed, because I suddenly realised I had this bias, expecting that people in their 80s or 90s wouldn't be comfortable using video, and I can remember some quite astounded older people telling me, but of course, doctor, I kind of regularly FaceTime my grandson or my granddaughter, and some people are just using it already. So that was really interesting. So I think we have to be very careful of not making presuppositions. And the other thing I found, which was really heartwarming, was when we as a practice started to say that we had a telehealth offering for patients, we would then actively encourage our older patients to maybe talk to members of their family. And I remember people coming back and telling me how this had been transformative, that their grandkids, who thought they were a little bit old and past it, were really enjoying sitting down and teaching them how to use Skype or whatever sort of poison they had in terms of the video solution. And that was really heartwarming. I think this is also a space for other organisations to step in. So the much maligned banks, here in Australia and over there in the UK, we actually teed up with one of our banks in the UK, who were pleased to provide a service where some of their staff would volunteer time to just sit with older people and explain how video consulting might work, and that was tremendous. And the bank was saying how that was wonderful in terms of demonstrating social responsibility, but also great from obviously a PR point of view, but obviously great from the older person's point of view. So I think that there are some solutions. And the other thing I would say is that certainly the experience that I'd had in a practice that was very heavily based around telehealth was that by helping those that could, we could actually more effectively help those that couldn't. So what I mean is that you suddenly found that telehealth consultations were happening, that people could use the service, which meant that face-to-face appointment times were freed up. And you could actually more easily accommodate people that just for various reasons couldn't use a telehealth solution. So actually everybody was a winner through this system.
So you've touched on the social isolation of patients, but I also heard something that I want to dig into a bit. You said that it was really delightful to get the specialist on the phone with the general practitioner and the patient. Could this potentially increase clinical collaboration and break down some of the isolation that people feel in primary care?
Completely. I mean, so here using one of the theoretical models, but something that's influenced me a lot is the work of the late great Clayton Christensen. His ideas of disruptive innovation, and Christensen certainly when he's talking about healthcare talks about having diagnostic solution shops. So it's this idea of having a really tight holistic diagnosis for a patient, and to be fair, in the vast majority of cases, the only way that you really get that rich diagnosis is by having all the right people in the room. And obviously, getting that to happen physically is nigh impossible. But using technology to get, your patient, their family, your primary care physician, nurses that know the patient, and then your secondary care specialist, actually talking about what's going on, really trying to drill out, what the diagnosis is and personalizing it for that person. That's just gold, isn't it? Absolute gold, because you know that if you can really get a tight diagnosis, you're going to have a much more effective management plan. And I think this is really the key thing, I think, about trying to have more of this happening, particularly for patients with really wicked, complex medical problems, where so much time is wasted for the poor patient, and endless kind of linear appointments. It's much better to just get this sort of a rich conversation happening to get a tight diagnosis.
Yeah, good. 15 minutes goes really fast, but I'm interested if you've got any closing thoughts outside of telehealth. Do you think there are going to be lasting changes for our model of care, or policy required, or culture in our society? What do you think?
Do you mean as a result of COVID? Well,
Yeah.
I think I'm probably more at the. I can't say that I think that they will, but I certainly hope that they will, Simon. I mean, I think I'm probably. I probably would align myself to that group of people that don't really want to snap back to what we had before. I really don't want that. I think having gone through this collective pain and angst, and also accepting that so much good has come out of the COVID crisis, that we should capture and hold on to some of these elements, particularly around the use of telehealth, the environmental benefits that we've got in terms of working virtually much more. I think we need to hold on to those and actually then start to grow and redesign our processes around it. I mean, we've talked just about video in this conversation, but remote monitoring, is used a lot more in other parts of the world. We could be doing a lot more of that here in Oz. That would be tremendous. Using, really integrating wearable apps and the sort of way of holistically being able to kind of map what's happening to a patient in real time, all the time, and be able to see how we integrate that into consultations. We could be doing that. There's a lot more that could be layered on top of what we've already experienced, I think.
Well, the foundation is cultural, and so cultural change has been forced upon us. We're blessed to live in exciting times. I'm looking forward to some of those innovations changing our care and our outcomes in health. Dr. Jag, thank you so much for joining us today on Next Phase.
Thanks very much, Simon. Thank you very much.